Greetings from eMedi News and Heartcare Foundation of India. Welcome to our show, Chat with Dr. KK. Today we are going to have a chat with Dr. Mandeep Mehra, who is a professor of medicine, Harvard Medical School, and executive director, Center for Advanced Heart Disease at Brigham and Women's Hospital in Boston, USA. Welcome to our show.
Thank you so much.
24 lakh people die in India every year because of sudden death. 18 lakhs of them die before reaching the hospital.
Wow.
And the statistics shows, whatever, that 50% of such deaths we should be able to
Prevent. Yes.
Prevent, and if they happen, we should be able to revive them.
Yes.
So our topic will be very simple. Reducing, preventing, managing sudden cardiac death in different settings.
Certainly.
So let me take the first setting. Otherwise healthy individual.
Mhm.
Okay. Silent heart disease. Suddenly collapses. He collapses, he had a cardiac arrest. What's the role? How to prevent? How to reverse?
So suddenly.
Again, let me come back again. That in our mythology, we had such an example.
Oh, okay.
In mythology, there is an example. There was a lady called Savitri who wanted to get married to a person called Satyavan. The astrologer came and he said, you can't marry because he's going to die in 1 year. That means that astrologer was a medical astrologer. He knew that he has a disease which can cause sudden cardiac death.
Wow.
So he predicted vulnerable sudden cardiac death.
Yeah.
He says, if you're going to live with him, he's going to die.
Wow.
Then she says, no, I'm going to marry him. Then he said, okay, if you're going to marry him, be with him. Be with him.
Wow.
All the time.
Wow.
That means, and
so that you have an opportunity
you have
to
an
resuscitate.
opportunity to resuscitate.
Wow.
When they were traveling together.
Yeah.
He suddenly had a cardiac arrest.
Yes.
Yamaraj came,
Yes.
according to the mythological
Yes.
story.
Yes.
And then she fought with Yamaraj.
Wow.
And that fighting with Yamaraj probably was the first CPR in our mythology.
Wow.
And she won over it.
Wow.
Yamaraj went away and she revived back.
Extraordinary.
And that's our mythology talks about Savitri Satyavan.
Extraordinary.
That she fought Yamaraj.
Extraordinary.
And probably that might have been the origin of CPR or imagination of the Rishi Munis that such a revival is possible.
Wow. How wonderful.
Okay.
How wonderful.
So to prevent that,
Yes. Yes.
if that was available at that particular moment,
Right.
where did it disappear?
Right. Very interesting. Extraordinary observation. So the sudden death in healthy individuals can range from a variety of different problems. You can have rare but genetic causes. So these are you can do every diagnostic test in cardiovascular medicine and detect no structural disease, yet someone could be prone to sudden cardiac death if you have an ion channelopathy, for instance. This is a genetically predetermined form of sudden cardiac death, like a long QT syndrome. Rare. A second instance could be a situation.
Here I'll come back.
Yeah.
Because when a person is going for a competitive sports, a child or a youth is entering a competitive sports, is it a must for him to undergo evaluation for sudden death?
No, I don't think so. I think the second area that I was going to point out is in the situation of competitive sports, as you point out, where you may have structural heart disease that's silent, such as hypertrophic cardiomyopathy, or a congenital abnormality with the coronary arterial circulation, or some other underlying congenital heart disease that predisposes to sudden cardiac death. Now, some have argued, our colleagues in Italy have argued, that there should be extensive EKG and even echocardiographic testing in children entering or young athletes entering competitive sports. In the United States, at least, we have shied away from that because we have looked at cost-efficacy data, and it suggests that the amount of money that would have to be spent to perhaps save one potential life is nearly in millions of dollars if you do population-based screening. So the best we can do is look for predisposing risk factors in patients. So for example, if there is a child entering competitive sports, a healthy young man entering competitive sports, but there's a history that one of his siblings died early without a known cause, then you should evaluate them. If there's a history that this individual is entering competitive sports but has a history of recurrent syncope, for instance, then you should evaluate. If he professes any symptoms of palpitations, then you should evaluate. Even then, the evaluation can be difficult because distinguishing an athlete's heart from hypertrophic cardiomyopathy may itself be very difficult. And one of the ways in which we do that echocardiographically is that athletic hearts, even though they hypertrophy, they tend to be more dilated than hypertrophic hearts. But it's tough. Another way to evaluate for this risk of sudden cardiac death in competitive athletes is to actually do exercise physiology testing in these patients. If they have a blunted exercise curve on a treadmill test, that should be a very, very strong marker that this could be a.
So what do you measure there?
So if you place them on a treadmill test and they in fact don't have a expected rise in blood pressure of at least 20 millimeters of mercury with exercise, that's a very, very strong negative prognostic marker. That usually indicates that you have uncovered a left ventricular gradient at the outflow tract.
Some people with exercise develop a significant LVOT gradient.
Yes.
Otherwise, they have no signs of hypertrophic cardiomyopathy.
Exactly.
You have precipitated or you have unmasked LVOT obstruction. These patients also at high risk.
These patients are at very high risk, and there's data to suggest that if your resting gradient across the valve is about 30 millimeters of mercury.
30.
No, 30. 30, which is a significant gradient, that predisposes you to a higher risk of sudden cardiac death.
Even if it is after exercise?
No, after exercise it should go up much higher, or with other provocative maneuvers. As you might imagine in hypertrophic cardiomyopathy, any maneuver that reduces the ventricular size is likely to provoke the outflow tract gradient. So, for example, if you decrease preload in any way, by Valsalva, for instance, you could uncover a gradient. Exercise is the other form of seeing how they react to the dynamic form of exercise vis-a-vis coronary blood flow, for instance, as well as the height of blood flow, stroke volume with exercise in the presence of a significantly uncovered left ventricular outflow tract gradient.
Now, again, general public, we have screened them.
Yeah.
Now, if still we will find that people will die suddenly.
Yes.
We have Amjad Khan, we have Vinod Mehra, we have Sanjeev Kumar, we have Shafi Mamdar, we have our Vice President Krishna Kant, who died in office with a sudden cardiac arrest. We have Sunil that died in office. And when people like them, who have best of the facility, they die. So therefore, the role comes as a bystander.
Yes, absolutely. So there are 2 points inherent in, you've described many phenotypes of individuals who had sudden cardiac death. And point number 1 is that there are many phenotypes of predisposition to sudden cardiac death. For example, one could have a sudden cardiac death from a sudden aortic rupture. It has nothing to do with a cardiac arrhythmia. The second form could be pulmonary embolism. You could have sudden death from pulmonary. Amjad Khan could have died of pulmonary embolism. I don't know. He was quite obese. He may have had deep venous thrombosis and died of pulmonary embolism. But the most common cause of sudden cardiac death is an arrhythmia, ventricular arrhythmia. And the most common cause of ventricular arrhythmia is underlying ischemic heart disease in the setting of left ventricular dysfunction or a hibernating myocardium. And so detecting that is perhaps the most important thing. Now, the question, of course, is doing unselected tests in the population is not going to work. One has to look for those individuals who probably have the highest risk marker profile to predict the presence of sudden cardiac death that may be covertly present in them. How do you do that? It's a very difficult question to answer. So one should be very vigilant. Uncontrolled diabetes, hypertension, smokers, for instance. These are people who are prone to premature coronary artery disease. The Asian Indian population is highly prone to early onset coronary artery disease. Hyperlipidemia is rampant. Insulin resistance is rampant. And detecting these should heighten the clinician's mind that you should look for some form of structural heart disease screening. What could that be? You could do echocardiography. It can be cheaply done now with these handheld echoes, and perhaps that will change the way in which we detect left ventricular dysfunction. Or you could even look at biomarker strategies. For example, you could measure natriuretic peptide expression in peripheral blood, and you might find that there is elevation of BNP levels or natriuretic peptide levels in a group of patients, and that should heighten your suspicion that there may be significant underlying cardiac disease present in that individual. It's difficult, and so it raises the second point that if you can't prevent it from occurring, or you can't detect the predisposition to it, or even if you detect it, then treating it is hard. What do you do when it occurs? What should you do? Perhaps the most important thing is that we need to teach the patients and their significant others and the population surrounding them on how to resuscitate patients with sudden cardiac death. Now, you have done an extraordinary thing, which we've been watching from the United States rather jealously, because it's very difficult for us to create the degree of activism that you were able to create with your very masterful creation of a very simple technique, CPR-10, understandable by the most intelligent people or understandable by fifth graders, school children. And you took that and you increased awareness not only about sudden cardiac death, but a quick intervention. Your importance of CPR-10 cannot be underestimated. You will end up saving thousands of lives with this technique. Now, another technique that's been used across the world is the placement of AEDs, or automatic external defibrillators, in various locations. Airplanes, airports, shopping malls are a classic example. Temples, maybe in India. Cricket matches, exactly, where there's so much excitement that you actually have broken heart syndrome. If you lose a cricket match, that's another cause of sudden cardiac death. Described in Indian movies where a mother hears of the terrible news of a child dying suddenly, and she or the father clutch their chest and they drop dead. And that's the classic description of Takotsubo, or broken heart syndrome, that's been described. Stress cardiomyopathy induced sudden cardiac death. There are so many varieties of this, but I think in terms of prevention, it's very important that people be not only taught that, but there should be certification programs. I think that school children should have certification of basic life support. I think that there should be certification that should be mandated in large businesses, even towers, for instance, that house commercial enterprises, should be asked to create certificates, of adequacy or optimum adequacy of providing resuscitation capability, with trained bystanders, including equipment placed at certain areas, because frankly, just CPR alone may not help. Because
I'll add into it that we were certifying people initially.
Oh, good.
And now we have taken it off.
Oh,
certification.
Yeah.
Because now we feel that if I start certifying, it becomes a legal responsibility.
Yes.
So nowadays the new thinking has been coming is that for a hands-only CPR, unless it involves mouth to mouth,
don't
certify.
Okay.
Because it's like
interesting.
Anybody can do it. Otherwise, what will happen is somebody will say, you were not certified. Why did you do it? If you do it wrong, legal complications will come.
Certainly.
So nowadays we have withdrawn the certificate only on this reason.
Certainly. But that's for individuals.
Oh, only bystander.
Yeah, only bystander.
But healthcare workers, it's a must.
Yeah. So I'm talking about healthcare workers. I'm also talking about, is there a social responsibility of corporations?
Absolutely.
So, for example, if you have an elevator in a tower, there's from time to time a mechanical check of an elevator. Why? Because something could go wrong. People could die. So why would you not create some systems in place that force adequacy of sudden cardiac death? If the problem is as rampant as you described, 24 lakhs of people, that's crazy. That's huge.
There's another formula we have created, and the formula is that if you can walk 2 flights of stairs, or if you can walk 2 kilometers if you can walk for 2 kilometers, or if you can sleep with your partner without any breathlessness or discomfort, your chances of sudden death are less.
Wow, that's great.
I mean, it's
Absolutely.
an indirect way of explaining it to the people.
Absolutely. Makes a lot of sense.
Another thing which we have created is a show which we teach it to the school children.
Oh, wow.
And Amrish Puri in India who died recently. He's supposed to be a villain. Ideal villain of Indian society's villain is Amrish Puri. And we teach to the students that Amrish Puri is sitting in his home discussing with people that my father is not transferring the property to me, and he wants his father to die.
Wow.
Because he wants his property to come to him. His father wants to be given to his younger brother.
Wow.
So he discusses, he plans.
Yes.
And in the plan, he says, I'm going to take sorbitrate and discipline out of the house.
Yeah.
I'm going to have an argument with my father.
Yeah.
And when he gets a heart attack, I'll make sure that he dies. Okay. So message goes up, discipline and sorbitrate.
Yes.
Then he argues with his father.
Yeah.
His father dies.
Yes.
Okay. Now he has to show to his mother and brother that I am the real son.
Yeah.
So he called everybody. He goes, mother, come here, brother, come here. My father has died. And then he says, my father, why you die? Why don't you get up? Why don't you get up? And he gets up.
And he gets up and he's revived. That's so great.
And he gets up. So that's
so
the thing
great.
which we teach to school children.
Of course.
It's a fun,
of course,
as well as it's a message.
Of course, absolutely.
Now, come back to preventing sudden cardiac death in heart failure.
Yes.
That's another subject,
Yes.
because heart failure is something.
Of course.
I'm not talking about CAD and other things.
No.
In heart failure, how do I prevent sudden death?
So the most important thing is the detection of left ventricular dysfunction and treatment of left ventricular dysfunction with ACE inhibitors and beta blockers, and in selected cases with aldosterone antagonists. We know now very clearly that all of these medications, specifically aldosterone antagonists and beta blockers, reduce the incidence of sudden cardiac death. So pharmacological approaches are absolutely important. In those patients who have received optimum medical therapy and yet have residual left ventricular dysfunction, they should be candidates for consideration for an implantable internal ICD or a defibrillator. Now, there's a cost effectiveness benefit ratio with that, and we can debate the utility of that all along. But if someone has a residual left ventricular ejection fraction less than 30% on optimum 3-drug neurohormonal antagonism, that then one should consider an implantable cardiac defibrillator. And that has been clearly shown to save lives, clearly.
What about CRT?
CRT has also been shown to save lives in those with left ventricular dysfunction, relatively mild to moderate and even up to severe symptoms of heart failure, and a left bundle branch block or widened QRS.
The QRS is more than 150.
150.
And LVV.
Yes.
So if there is there, you will refer the patient should go for
Should
CRT.
have a CRT with a backup ICD.
Now, let me again come back to ICD. Everybody in India talks about that. Don't give an option to the patient because of the cost factor. Okay. No. Let me come back to the question. The same option is not given when he has a knee arthritis. Everybody says, go replace it. Nobody talks about it.
Yes.
If a patient has a liver dysfunction, they say, go for a liver transplant.
Yes.
If a person has a kidney failure, they say, go for a renal transplant.
Yes.
A liver transplant in India costs 20 lakhs.
Yes.
Okay. When it comes to 20 lakhs, they never say, don't go for it.
Don't do it. Yeah.
They say, go for it.
Yep.
Then they don't say that it is costly.
Yep.
For a knee replacement, each knee replacement costs around 2.5 to 3 lakhs. And they don't even discuss with the patient. They say, no, you have to get it done.
Yes.
Don't worry about the cost. It will make your life simpler.
Yes.
And why the cardiologists in India
Yes.
are apprehensive about ICD, but not about the renal replacement, not about that?
I can't answer.
I think 3.5 lakhs or 3 lakhs is that's not
very
your
big.
job whether you can afford or not.
Right. But I think it's because you're treating an asymptomatic disease as a prophylactic measure, meaning that a patient, there's a chance that the number needed to treat is about 14 at 2 years with an implanted ICD in ischemic heart failure.
So that means 10% would die. You
That
will
means
save 10%. 10%
You'll
is the big
save
number.
10%, but you'll have to implant 9 more devices to save those that one life, right? Something like that. So the point being that in a prophylactic situation, that argument is very important to tell. If you can't walk and you need a knee transplant, you need it. If you're going to die and you're sitting with hepatic encephalopathy, you need a liver transplant, you need a liver transplant. Problem is that if somebody asks us, say, I know that ICDs save lives, but what is the absolute chance that it'll save my life? Well, it's 1 in 14 at 2 years. So that becomes a choice because 13 patients are not going to even use it.
Other way around. Yeah. You put the ICD in 100 people. How many of them will never have a shock in their life?
About 40%.
So 40% will never have a shock.
Now we have data out to 8 years, okay, where the number needed to treat becomes 1 in 2. That means by 8 years, only 1 in 2 people will have had their life saved from an appropriate ICD.
That's a big number.
It's a big
that
number.
If you want to live for 8 years, you need an ICD.
Yeah, half. That's 50%. But you asked a very specific question. You said how many may not need it? Half may not need it.
Half may not need it. Anything else in reducing?
Let's see.
What is the role of ivabradine in reducing deaths in?
I don't think we know that yet. I don't think the data is very clear. But as we say, we have just a certain number of heart rates to live, and we have a certain number of breaths. I believe, more importantly, that we have about 1 billion breaths really to live. But many argue that it's the heart rate, and in that sense, reducing your heart rate chronically with drugs like ivabradine may be a good idea. But the evidence is still
in heart failure.
Controversial in heart failure.
In heart failure.
Yeah.
At the moment, there is no definite evidence.
Not clear. Yes.
Not clear, but there's a definite evidence about beta blocker.
There's definite evidence about
So if
beta
a person
blockers.
cannot afford, if the person cannot tolerate beta blocker, should evaporating
I would recommend evaporating. Yes, absolutely, because there will be reduction in cardiovascular events, some of which will be related to sudden cardiac death, of course.
Tell us something about your childhood and funny activities. शरारतें क्या करते थे?
Actually, I was a very, very good child. You know,
You still are a good child.
That's true. You're always a child.
Absolutely.
Yeah, either you're a child of your parents or you're a child of humanity at some time point. So, absolutely. No, I was a really good kid. I always studied hard. I was always focused. I didn't look around too much. You know, I stayed very focused. I actually followed your lead in medical school. You know, we were brought up with your name as an ideal name, and we said, you know, we've got to be like Krishan Kumar Agarwal.
Thank you. So thank you.
Thank you so much.
Be with us for this show.
Thank you.
And so that's all for today. We'll come back with one more show. Till that, goodbye. Thank you.
Thank you.